This is the final presentation in a series of presentations on radiography of joint disorders in veterinary patients. The intent of this presentation is to provide case-based practice to help you identify abnormalities of the musculoskeletal system and to help you apply the knowledge you have learned to determine a diagnosis or develop a prioritized differential list. Although I won't spend too much time reviewing each study in this presentation, remember that you should be practicing review of studies by finding a systematic approach that works for you and then being sure to use it consistently and review the entire image for each study each time. And I want to encourage you to always practice writing your findings down and being as descriptive as possible using the correct anatomic and radiographic terms before you then come to conclusions on each study. Let's start with case 1, which is a 3-year-old neutered male Samoyed who is presenting for acute lameness in the right pelvic limb. If you look at the images, we have orthogonal views of the crus, and these views were actually made on, if you look on the lateral, in that TPLO view that I talked about before, where the stifle is in 90-degree flexion and the tibiotarsal or tarsal crural joint is in 90-degree flexion. This is a nice lateral view, and then this is our cranial caudal view. And notice both views are going to include the joint above and the joint below, and it's a really good exposure, so a good study. I like to look at overall alignment next, and when I look at this patient, the alignment on the cranial caudal view looks good, but let's look closely at the lateral view. As I look at the femur and tibia, I notice from the things that we learned about in our discussion on the cruciate ligament, I notice that the alignment of the stifle is not normal. So I'm looking at this intercondylar eminence of the tibia, and I'm seeing that instead of being in its normal position, which remember when we look at the femoral condyle, divide it roughly into thirds, that intercondylar eminence should be positioned in about the middle third. It is actually too cranial. So this is cranial location of the tibia relative to the femur. And so I have seen that there's a problem with alignment here. Looking down the rest of the limb, there is appropriate alignment. Then I like to look at the soft tissues, and all of the soft tissues look okay with the exception of the fact that I see this soft tissue increased opacity and size associated with the stifle. The soft tissue here is too large. It's displacing that infrapatellar fat pad. It's kind of squishing it as well. And then back here on the caudal aspect, it's displacing this fascial plane. And so this is soft tissue swelling of the joint itself, or that intracapsular swelling, and I would call this a moderate amount. So moderate intracapsular stifle swelling. I see a little bit of soft tissue swelling that is more medial to the stifle on the cranial caudal view, which may actually be some extracapsular swelling. So next I want to look at the bones themselves, and when I'm looking at my study, I usually go proximal to distal. So I'm looking at the cortex, the medullary area. And when I get down into the joint, I'm going to look at the periarticular areas as well as the joint surfaces. And in this patient, I'm noticing some mild but present periarticular changes. So I see a little bit of irregularity from osteophytes on the medial epicondyle of the femur. I also see these small little points that are osteophytes on either side of the tibial condyle, so medial and lateral. I also see a little bit of extra bone forming on the proximal and distal patella, so these are all osteophytes. The articular surfaces themselves and the subchondral bone look good, but when I come to the cranial aspect of this tibial plateau, I see that there is new bone proliferation here, which is proliferation at the site of insertion of the cranial-cruciate ligament. And so this is that term enthesopathy. So bone that's forming at origins, insertions of ligaments, tendons, and joint capsules. And then it's also surrounded by some subchondral sclerosis. The remainder of the bones, I think, are normal in this patient. Notice this little mineral opacity, that is a normal sesamoid. That's our popliteal sesamoid. I can see it more clearly because it really has not moved in its position when the tibia moved. So it's actually a little bit displaced from the tibia now. So all of these findings together are going to tell me that there's instability in this stifle. So that would be actually a complete rupture of the cranial cruciate ligament. But I see some osteophytes, which would be from degenerative joint disease, and I see this enthesopathy that's at the insertion of that cranial cruciate ligament. So I know that this process has been going on for a while because there is some osteoarthritis and there has been enough time for changes to happen at the insertion of the cranial cruciate. So this is actually a stifle with chronic disease of that cranial cruciate ligament. So that cruciate ligament has likely been degenerating. And then what might have happened is there was a partial tear that acutely ruptured. And so that would explain the acute lameness. However, the radiographs tell us that this has been a chronic process. So chronic cranial cruciate ligament instability with osteoarthritis that then has likely completely ruptured. Case number 2 is a 3-year-old paint mare who's presenting with lameness and left tarsal swelling. Notice that we have the 4 standard views of the tarsus, and I typically will put them up in this order. Again, it's part of my systematic approach to also consistently display them. So this is our lateral, this is our dorsal plantar, this is our DMPL view, and this is our DLPM view, and you should be able to refresh your memory on how to name those using your normal anatomic markers in this part of the patient. These are good quality studies. They're nicely centered and collimated. They're good exposure for our bones. So I don't see any problems with alignment through any of these bones, but when I look at the soft tissues, I do actually see focal soft tissue swelling, also a little bit here on the plantar aspect that is centered at this tarsocrural joint. I see most of it kind of at the kind of dorsal aspect and the plantar aspect of that joint, but there probably is a little bit at the lateral and medial sides as well. That is centered at that joint, so we're going to call that intercapsular or joint-related swelling. A little bit of the swelling probably extends down toward that proximal intertarsal joint, but remember those 2 joints communicate, so this swelling can be secondary to the tarsocrural swelling. So then looking at the bones and the structures related to the bones, I really only have a couple findings. On this lateral view, I'm noticing that there seems to be this separate osteochondral fragment or joint mouse here at kind of the dorsal aspect of that tarsocrural joint. I'm not sure I can tell exactly what it is associated with on this lateral view, so let's look for it on another view. Can't really identify it on the DP view. That's probably because this more dorsal part is going to be superimposed over the rest of the structures. But on the DMPL view, I can see that there is this separate mineralized structure here at the level of the distal tibia is where I think it's coming from, and we'll talk about that in a second. I also noticed that there are probably 2 or 3 separate fragments, osteochondral fragments, instead of just one that it looked like on the lateral view. Adjacent or nearby these fragments, I see that this structure, which is the intermediate ridge of the tibial cochlea, has a focal concave defect. And if you've forgotten what that looks like, go back and look at a normal. And then surrounding that defect is subchondral sclerosis. I probably am seeing the fragments sitting here on my DLPM view, but they're not as clearly identified. So in this patient, with these findings of the intermediate ridge, the associated osteochondral fragments, and the joint swelling, there really is only one diagnosis, and that is osteochondrosis dissecans. And in this patient, it's dissecans because there are the fragments. Now, I am not going to get really concerned about you being able to pick out on a test, does this patient have osteochondrosis or does it have osteochondrosis dissecans? I think we should look for those fragments, but really it's all the process of osteochondrosis. This is not a fracture. This is not a sequestrum. And why we know that is because we know that this is a specific location in the tibia that a patient will develop osteochondrosis. This patient is still young, and so this is a lesion that is obviously a time that we would typically see it and is causing the lameness and swelling of this patient. However, remember that sometimes we can find these lesions in much older patients because once they're there, if we haven't corrected them, they'll always be there. So developmental disorders can be present in skeletally mature and older patients. But then if it wasn't an older patient, we'd need to make sure that it was actually the cause of the clinical signs. You do need to know the sites of osteochondrosis, which joints, and then which specific parts of which bones in the dog and the horse. You'll need to be able to know that for taking a test, but also for future and in your practice. In the horse tarsus, remember the intermediate ridge of the tibial cochlea was the most common location, but our trochlear ridges of the talus can be affected. Most commonly the lateral, but sometimes the medial. Then there was that proximal tubercle of the talus that's kind of located in this area that could get osteochondrosis. And then the medial and lateral malleoli could also get osteochondrosis. Case number 3 is an 18-month-old neutered male Labrador Retriever who has been intermittently limping on the left thoracic limb after yelping out during free time in a dog park about 2 weeks ago. So it sounds like maybe there was an acute onset of lameness and it hasn't gone away. So we have orthogonal views of the elbow, a lateral and a craniocaudal view. They are nicely positioned and nicely collimated with good exposure. I started out looking for any problems with alignment. I don't see any problems with alignment on this portion of this limb. And then I like to evaluate for soft tissues. When I look at the soft tissues, when I get near the elbow, I do actually see this increased kind of cranial soft tissue opacity and enlargement that is centered at the elbow. I also see this increased kind of soft tissue opacity and size at the caudal aspect of the elbow. And then medially here is an additional site of soft tissue swelling. So this is all centered at the elbow. So I think that this is probably joint related or intercapsular soft tissue swelling of that elbow. Looking at the osseous structures next, I just want to point out that in the dog humerus, this is a pretty normal appearance of the distal humerus. It starts to get more loosened because the bones kind of separates out where there's that trochlear notch here. So there are thinner areas of bone, and this really kind of coarse and fine trabeculation is also normal. So the humerus in this area looks normal. When I get down into the periarticular area, I do start to see changes. I see on the medial humeral epicondyle, when I look on this craniocaudal view, that there is irregularity from new bone, which we're going to call osteophytes. I can see those here. This is the medial humeral epicondyle, kind of superimposed over part of the olecranon of the ulna. So those are osteophytes. I also see osteophytes here on the radial head. So this is not a normal contour of the radial head. Probably even a little bit of osteophytes on the cranial aspect of this humeral condyle. I can't really evaluate the anchineal process, that kind of proximal area, which is another area that we might find osteophytes because of the superimposition. I think there is even some sclerosis here of the trochlear notch of the ulna. So a lot of these changes that are osteophytes and are consistent with degenerative joint disease. So this is a pretty young dog, and this dog has degenerative joint disease. And so I need to actually consider that this patient has elbow dysplasia. But remember, I wanted you to not just stop with saying, hey, this patient has elbow dysplasia, and I would call this moderate degenerative joint disease, but we need to look for the underlying cause. And there were 3 underlying causes we learned. The first and most common was medial coronoid process disease. The second is probably the second most common is osteochondrosis. And remember that involves the medial aspect of the humeral condyle. And then the ununited anchial process. And so we can start to look for specific changes for those diseases. Let's start with the medial coronoid process, since that is our most common cause. If you remember on the lateral view, we can look for normal contour and clarity of the medial coronoid process here, superimposed over the caudal part of the radius. I should see a nice discrete triangle of bone, which would be our normal coronoid process medially here. All I see is kind of this indistinct and abnormal contour. So it starts to make me wonder if that is abnormal. So when I go to the cranial caudal view, remember that this is medial. This is the medial coronoid process, so coming off from that ulna. This is quite abnormally shaped, has some probable excess bone. And then if I look really closely, I think there is a radiolucent line that goes through this piece of bone adjacent to the medial coronoid process. Next, we talked about osteochondrosis of the humeral condyle at the medial aspect. So let's take a look at that. So here's our humeral condyle. This is the lateral aspect. That looks pretty good. When I get here, there is kind of this little kind of articular contour change with some subchondral lucency. And then when I look at all of the subchondral bone in that kind of medial aspect of the humeral condyle, it's quite opaque when we compare it to the part of the lateral condyle I can see. So there's subchondral sclerosis. And then the final thing we talked about was the anchial process being ununited. And I can see this anchial process, and it clearly does not have a separation of a radiolucent line between it and the rest of the ulna. So that is normal. So all of these findings together, especially the findings of the medial coronoid process, tell me that I believe this patient has medial coronoid process disease with an actual fragment identified as a primary underlying cause for the elbow dysplasia and secondary moderate degenerative joint disease. But let's talk a little bit more about what's going on in this medial aspect of the humeral condyle. This certainly could be a small osteochondrosis lesion, because that's what it could look like. And a patient may have more than one developmental disorder at the same time. So elbow dysplasia, they could have 1, 2, or all 3 of those underlying causes. So it's possible this patient also has osteochondrosis. But the other thing that can sometimes happen secondary to medial coronoid disease is that you start to get secondary articular cartilage and subchondral bone changes on the opposite articular surface, which would be that medial articular surface of the humeral condyle. When that happens, the cartilage is damaged and then the subchondral bone starts to remodel. That can be called a kissing lesion. So it's secondary to that medial coronoid disease. Now, I can't tell for sure which one those are, so those will be my differentials. Now, this has obviously been going on for a while, because just like any joint, it takes many weeks to maybe even a few months to develop degenerative joint disease. But maybe what happened to cause the more acute lameness is that whatever misstep or trauma, this little fragment that was maybe attached to the medial coronoid process initially just kind of got jolted and displaced and is causing more of an acute synovitis. So that can certainly happen. This is a companion case to the last one. This is an 8-month-old dog, intact male Labrador Retriever. This dog also has elbow dysplasia, although there are no findings of degenerative joint disease yet. It's probably too young. However, when I look at this patient, I can see a normal contour of the medial coronoid process on both of my views. I can see a united anchial process, so that is normal. But when I look at that articular surface of the medial aspect of the humeral condyle, I see a small, subtle articular lucency and concave defect, and then associated subchondral sclerosis of that part of the condyle. So this patient has a finding, pretty subtle, but still present and causing the lameness of osteochondrosis of the medial aspect of the humeral condyle as the cause for the elbow dysplasia. So remember, I'm not going to have you just say the patient has elbow dysplasia, but I want you to look for the underlying cause. All right, case number 4 is a 10-year-old neutered male Labrador retriever who has right pelvic limb lameness, and the clinical suspicion is cranial cruciate ligament disease. So they've obtained those TPLO views that we've already talked about. So a lateral and a cranial caudal that are well positioned, pretty good exposure, and have all of the parts of the bones in that we want. So looking at this patient, overall alignment, especially compared to the first case, I don't see any issues. So here's our intercondylar eminence of the tibia, and it is nicely positioned in that middle third of the femoral condyle. So the stifle is aligned in the lateral plane, tarsus is aligned. I don't see any problems with alignment in the craniocaudal plane. Soft tissues are not normal. What I see is quite a bit of soft tissue swelling that seems to be associated with the cranial part of the stifle joint, almost complete obliteration of that fat pad. But I also see quite a bit of soft tissue swelling caudal to the stifle that seems to be going more proximally and happens to be proximally on the medial and a little bit on the lateral side. And so it's more involving the distal femur as well as that stifle joint. So a combination of intracapsular and extracapsular swelling. When I look at the bones, I'm hoping that we can all recognize that there are quite a few changes going on in the femur here. So I see areas of lysis. This area might be geographic, but then there are areas of moth-eaten lysis more proximal, and this is affecting predominantly the distal metaphysis and probably a little bit of the distal diaphysis of this femur. Notice that there are areas of cortical lysis cranially and caudally. This patient has some periosteal reaction on the medial and lateral aspects of the distal femoral diaphysis and metaphysis. It looks fairly solid and smoothly marginated. But then on the caudal aspect, I see kind of some wispy reaction. So there may actually be some amorphous periosteal reaction. And then finally, this lesion is not very discrete. So there is a poor transition zone or long transition zone with poor margination. When I look at the articulation of the stifle and I look at the patella and I look at the tibia and the fibula, I do not see any other osseous lesions, and going down the leg, they look okay as well. So what I am identifying is an aggressive looking lesion. So that is because of the pattern of lysis, the cortical lysis, the pattern of periosteal reaction, and the indistinctness of the lesion. So an aggressive lesion that is in only one bone. It's in that distal femoral metaphysis. And so the really only differential I want to put on my list would be a primary bone tumor, because this is a 10-year-old dog. So that's really my primary differential. And then osteosarcoma would be the most likely, and this is certainly a location that osteosarcoma likes to be. Now, could this be fungal osteomyelitis? Sure, that is possible because it does like to be in the same places and can still affect just one bone in the area that we're looking at as primary bone tumors. But I just think that that is unlikely in this 10-year-old dog. This is not a joint-related tumor because the lesion is in the distal femoral metaphysis. It is not related to the kind of joint margins perarticular, and there are not more than one bones involved. This last case is a companion case in a 10-year-old spayed female German Shepherd dog, and this has some similar but additional findings to the last one. So first of all, there's quite a bit of irregular mass-like soft tissue swelling that seems to be centered at the tarsocrural joint, but also involves the distal tibia. When I look at the bones in this area, I do see that there is moth-eaten lysis of the distal tibia. It seems to be more kind of peripheral, maybe more at the kind of lateral aspect of the distal tibia here, and then a little bit more caudally. But then when I keep looking, I see that there is also moth-eaten lysis in the talus that also seems to be a little bit more at the lateral aspect, but also maybe at the kind of dorsal aspect centrally here. And then I also think that a part of the calcaneus is probably involved as well. So lysis of 3 bones, kind of in the area of that soft tissue mass-like swelling. Then there is some periosteal reaction on this caudal aspect of the distal tibia that seems to be a little bit spiculated, and maybe some reaction on the talus here, and then some spiculated reaction on the calcaneus. So in this patient, we actually have multiple bones, so it's a polyostotic lesion, and it is centered at the tarsocrural joint, and a lot of this lysis seems to be kind of peripheral at the joint margins. And so this would be very consistent with a joint-related neoplasia, like a soft tissue sarcoma. Certainly another sort of soft tissue tumor is possible. Is fungal osteomyelitis possible? Sure, I think that's much less likely. And then this is not typical of an erosive arthropathy, because notice the articular margins are spared and there's no subchondral bone erosions. So again, this would fit better with a soft tissue neoplasm. Be sure to consult references for additional examples, and don't forget that you can go to the Canvas website under the general information to click on the link for this veterinary radiology website, where you can look through modality, region, and species and be able to find some additional practice cases that you can look at first, do your findings, do your conclusions, and then you can look at the posted answers for those cases. Remember, practice, practice, practice is only going to make you better.